So, first of all, apologies. The flight got delayed because of Republic Day issues in Delhi, and our flight got delayed, though others were here in time, but that's how it is. So, I've just tried to refine the title, keeping the time in mind, how to make the eye comfortable with glaucoma meds. First of all, the important thing is, does the eye need the glaucoma med? I'm a firm believer there is more over treatment for ocular hypertension and early glaucoma. Patients actually don't need it, and one of the reasons is because the treatment is started based on single values of NCT alone. Whatever you do next, whether you do field, OCT, gonioscopy should come later. What I feel is you should do applanation, and with that 30 to 40% of the patient who you think will need treatment will actually don't need treatment. So this is the important thing, because my talk is based on ocular surface related to glaucoma meds. Actually, we overtreat a lot in the early stages, and that is something we don't need. Also, please remember that ocular hypertension, which you will be dealing with much more than I will be dealing with, the target pressure is not 18 or 19. That means sometimes even 24, 25 pressures, up to that you don't need to treat. So again, starting with 20, 21 pressure, single reading, you start treatment. I think that is not correct. That will all come under over treatment. Also remember, in Uttarakhand and Dehradun, where we are today, half of all primary glaucomas are angle closure. And they will not need treatment if you can do the correct treatment for the angle or the narrow angle part itself, because you are seeing them very early. So these are the things. Does the eye need glaucoma med? In a lot of these situations, they don't need treatment. Same thing, a lot of the secondary glaucomas you will see first, and here you may not need to give glaucoma med if you can treat the primary cause first. So addressing the primary cause or not addressing the primary cause in secondary glaucoma and starting with glaucoma med will not help us. A dissuspect, again, this is OCT is I feel it's basically a lot of the patients are being treated based on single OCT scans. They are started meds which actually the OCT is not a correct report, it's a fallacious report. So in dissuspect or OCT alone, I think these are again qualifying as over treatment. Same thing, other spectrum, a pressure of 14 with a dissuspect, we are labeling them as normal tension glaucoma and giving one drug, two drugs, three drugs. All this is over treatment. All these situations I've highlighted in the first two slides. Does the patient need, or does the eye need treatment? All these, they don't need treatment if you can address the actual one. Now, let's do the next step. You presume now that you decide that the patient needs actual treatment, and then the golden rule in medical management of glaucoma is to use monotherapy. If we remember this golden rule from this conference, I think the whole exercise is fruitful. In Delhi, where I practice, the most commonly started drugs for ocular hypertension or early glaucoma are brimonidine timolol combination or dorzolamide timolol combination. Now that is not correct practice, because why do you need to give two meds? You can easily give a single med, use one like I've said, written here, then follow up the patient for 3 to 4 weeks. Remember that even if the pressure is 24, 25, 26, when one med, it may not suffice, but the patient is not going to go blind in 3 weeks. So you start with this one med thing, follow up the patient for 3 to 4 weeks, and if necessary, add. Now that is okay, but what I would do in that regard is I would still not give this as a combination. I would give a prostaglandin actually, which is even for early to moderate glaucoma. And if you give prostaglandin, it will suffice for most early to moderate glaucomas, is my bet. Remember, the golden rule is in the first line, give one drug or monotherapy. And with prostaglandins, I'm going to reiterate, आप अगर prostaglandin देते हो तो early to moderate glaucoma तक, lot of these patients can be tackled by one drug or one bottle alone. Now, what about the correct drugs? A patient is already having dry eye, और एक ड्रग देना है. ड्राई आई का पेशेंट ऑलरेडी है, उस पर हमने एक ड्रग देना था, हमने टिमोलॉल दे दिया, which is not correct, because remember that this is the most dry eye causing glaucoma drug is timolol. So this is not a correct thing or choice. What about a patient is prone to having allergy? Seasonal allergy है, उसमें हम ब्रिमोनिडीन देते हैं, एक ही ड्रग देना था, हमने ब्रिमोनिडीन दे दिया. This drug is known to cause allergic blepharoconjunctivitis, blepharitis and conjunctivitis. Or drugs देने थे, एक drug देना था, you can choose any other drug. So this was not the correct choice in that patient. Remember, between dorzolamide and brinzolamide, dorzolamide is a more acidic drug. And when we are talking about ocular surface, if the patient has stinging and it stings for more than 10 seconds, then I think you have to change it to brinzolamide if you have to choose that drug, because one, it's a suspension is brinzolamide and it's less acidic than dorzolamide. Please remember this. Amongst the prostaglandins, bimatoprost and travoprost are more likely to be, causing problems with ocular surface. So if your patient is having a problem with these two drugs, I know travoprost is the hot favorite here. That is the #1 prostaglandin which is prescribed in Dehradun. And शायद मैं गलत नहीं बोल रहा हूँ. And अगर आपके उस patient में hyperemia हो रहा है, see, I got a prescription the other day from Delhi only. Travoprost दिया हुआ है, hyperemia हो रहा है और साथ में एक drug दिया हुआ है loteprednol LS. No, that is not correct. In that regard, you can straight away shift to a latanoprost, which is more an eye friendly or ocular surface friendly prostaglandin. And definitely with using first line of ripasudil and netarsudil, I am not in favor, and that's why I have put a cross there. बेटा ये शायद नीचे कुछ स्लाइड कट रही है, लास्ट लाइन नहीं दिख रही मेरी स्लाइड की, थोड़ा सा आप इसको थोड़ा सा वो छोटा कर दो. I'll tell you what was there in the last line. I had written pilocarpine. And pilocarpine, when no other drug is going to work amongst these, please try pilocarpine. It's a very good ocular surface friendly drug. So that is something which I wanted to say. Now I'm a big fan of combination therapy. Yahi tha na slide? Okay, yeah. So I'm a big fan of combination therapy. One reason is because it gives you reduced overall preservative load. And we are lucky in India, we are fortunate in India that timolol is available in combination with all other drugs, including ripasudil also. ROCK inhibitor is also available as combination. And this is the main reason for prescribing, and that will also give us the rule which I said. Overall, we are still using less bottles. Giving it separately, say brimonidine separately twice a day and timolol separately twice a day, may not be the correct choice. Give combination therapy unless there is a reason not to give it. We also have brimonidine and brinzolamide, and I think very soon we are going to have this in India, latanoprostine and netarsudil combination, which will add to our this thing. It's going to be launched. हो गए बेटा 15 मिनट हो गए ओके नहीं पर 15 मिनट हो गए क्या ये 8 का अच्छा because I have just come default 8 लगाया था नहीं seriously if I have to finish I can run all right okay because I thought I just started anyway and we also have in India, which is not available anywhere else in the world, the triple combination therapy is also available. So overall this is the reason to do it. तो ये लिखा हुआ है ना Arshi, we'll stop because time's up. So this is the algorithm that I follow. Prostaglandin first, and the reason for choosing prostaglandin, there are many, but for me the most important one is the good day and night time control, दोनों दिन का और रात का control of IOP with a single bottle. Then we use a prostaglandin timolol combination therapy. Next would be if you have to escalate your therapy, prostaglandin, brimonidine timolol, dorzolamide, pilocarpine timolol, any of these you can choose as per what we've discussed in the previous ones. And next would be 2 bottles, and very rarely if this is not agreeable, then we can shift to ripasudil and netarsudil. I follow the 2-bottle rule, and something which I would like all of you to follow also. The 2-bottle rule, uske baad kuch aur karna hai, which I'll tell you in the next slide, which will have 2 bottles can have 3 to 4 meds. This is the most ocular surface compatible therapy. So beyond 2 bottles, we can do SLT, or if you don't have that, you can use the 532 nanometer trabeculoplasty. The retina laser is available everywhere in Dehradun. So we can use this as a third bottle if you like, beyond 2 bottles, and you can repeat it twice, and usually that will suffice for about 2 years, and I think that is quite a good time. Starting MIGS early, if your patients are intolerant to out of the 3-4 doing MIGS early, I think will be a good choice now going forward. TRAB, of course, is an option, retrab, glaucoma drainage device, and if all these do not work, then we can also do a supplemental partial CPC. So ACG, the disclaimer is, half of all patients are that, like I said, you have to either do a YAC-PI and or a lens extraction, and then keep on following the 2-bottle rule that we did for open angle glaucoma. Now, a few slides about preservative-free therapy. The actual preservative-free therapy is going to be UNIMs. And again, exciting times. We had UNIM 2 years back. The company was banned, or it's closed down. Now again, in the next 2 months, we're going to have a UNIM of a prostaglandin coming in India. Let's hope it works better. Alternative preservatives are another one. Instead of BKC, you can use this. And then you can have the special bottles. So let's devote the next 4-5 slides to this. So 60% or 2/3 of patients using glaucoma meds will have ocular surface. So this is a big problem. And because of the chronic therapy, the more number of drugs, use of preservative-free drugs is a good choice. These are the type of preservatives which are available in India, and I think all of us are familiar with this. Some of these are patented, some of them are available across the board. So effects on the cornea, epithelium, the healing process is slow, conjunctiva, goblet cells, tear film, and the inflammation. And the tear film part is all the parameters are affected by preservatives. So I think this we can skip because we have already said that BAK is harmful and we should try to avoid this as far as possible. So the surgery part, which is my forte, we do, the surgery is going to be affected if the ocular surface is bad. And that is why preservative-free therapy is the strategy to use much earlier. If possible, start with preservative-free therapies only, and that is what this thing is. So yes, these are the specific situations in which you must do, but can we use preservative-free therapy for all? I am an advocate for this, and try to start with this because एक bottle, 2 bottle, but बाद में जब surgery करनी होगी, the failure rate is much higher unless we can start with this in the initial phase. And it is not without basis we are talking about this. The newest EGS guideline is talking about preservative-free therapy, and I'm sure in India also it's going to percolate down this year and next year. So just some studies which are showing this, that there is a lot of difference in all the parameters we have discussed in preservative-free therapy. So the discomfort part, reduction in signs and symptoms, and about 1/3 decrease in the hyperemia. So the bottles part, the third part we were talking about, there are the Novelia bottles and the Aptar bottle. And I think the Aptar has come back. It was a problem with this. Now it's come back last year. After Diwali, it's come back in a big way. And I think it will be available. So there is always, विनोद सर, ये बोला जाता है कि प्रेजर्वेटिव फ्री देने से आईओपी लोअरिंग खराब होगा. ये बोलते हैं सर, बहुत से लोग बोलते हैं. So there are many studies which have shown this. So I think we can just we can agree that preservative free देना है या preservative के साथ देना है, the percolation of drug is equally good, and many studies have shown that IOP, which is our main target, is equally good with that. So this is with bimatoprost and timolol combination. This is showing the same thing. The IOP reduction is matching. This is with dorzolamide and timolol. Again, you can see the IOP lowering is matching. And as scientists, we need to see the evidence, ocular surface, the hyperemia, burning, stinging, adverse effects, all are much less in the blue when you give preservative-free therapy. This is adherence and satisfaction, which Julie will talk about. So this is the last slide. आपने ये सब तो समझ लिया, but the supportive therapy. If we don't tell our patients, एक ड्रॉप ही डालना एक बारी में, वो पेशेंट कहते हैं आपने बताया नहीं, हम तो दो दो डाल रहे हैं एक बारी में. एनी ड्रग, चाहे वो प्रेजर्वेटिव फ्री होगा, तब भी उसको एलर्जी करेगा. सो दिस वी मस्ट स्पेंड टाइम. और आपके पास पेशेंट बहुत पहले आता है, मेरे पास तो बहुत लास्ट में आता है. एक ड्रॉप ही डालना है किसी भी दवाई का, ये बताना है उसको. फिंगर पंक्टल ऑक्लूजन, उससे क्या होगा कि अगर वो फिंगर पंक्टल ऑक्लूजन ये वाला अगर आप कर सकते हो, तो उसको शायद दूसरी दवाई की जरूरत ही नहीं पड़ेगी, क्योंकि वो पहली दवाई का ही इफेक्ट इतना अच्छा आ जाएगा. सो दैट इज अ मस्ट, वी मस्ट एजुकेट दैट पेशेंट. लिड क्लीनिंग, कोई भी दवाई होगी अगर थोड़ी सी भी बाहर आएगी, इट इज नॉट मेंट फॉर द स्किन. So please educate them to use soft tissues, and they must clean the eyes. This is very important. Also, the lubricants we write should be preservative free ideally, and there are many lubricants now which are preservative free, so this will help us. And if you have to, you can support your anti-glaucoma drugs with cyclosporin or levetiracetam. I think this is the way to go, rather than giving, Ajay sir, rather than giving loteprednol or fluorometholone. I think we should resort to this. अब धीरे धीरे इनकी कॉस्ट भी धीरे धीरे इंडिया में बहुत कम होती जाएगी. This should be your supplement rather than giving a low dose steroid also. I am thankful for everyone, for the patient waiting for us, and I'm sorry but I am here. I am very delighted to be in Dehradun, Uttarakhand. सर कम बुलाते हैं मेरे को, पर जब भी बुलाते हैं मैं हमेशा आ जाता हूँ सर. Thank you so much.